this is a bit of introduction for you about me, that slide itself. I work in various medical institutions as a senior faculty. I have more than 50 years of teaching experience. So I hope you will be able to garnish the available knowledge from me. My passion is to teach from the beginning. So that's why I'm here. Now, the topic for today's discussion is hyponatremia. Those of you online also, please note down if you have any questions you can raise at the end. Roughly about 1 hour we will go from now. And we will stop at that point and see if necessary we will continue. So hyponatremia is such a common thing. Most of us do not think it is so. That is the reason we need to be very alert in picking up the patients of hyponatremia. Remember, hyponatremia means sodium going down is not the correct. It is the water metabolism which makes the sodium high or low. If the water is more in the body, the sodium appears lower. If the water is less and hemoconcentration occurs, sodium levels rise. Generally, this is the picture. Disorders of sodium per se are not that common. Disorders of water and secondary deficiency in hyponatremia is the common. You all know that 35% of the body water is 35 liters. We are around 70 kilograms. 50% of the body weight is water. In women, it is 55% is water. In obese men also, it is higher. Why? In the adipose tissue will not allow for the adipose tissue, body water 55% in male and 50% in 55 in male because the adiposity is less. In women, it is because of the adiposity, the water content is slightly lesser than that. In obese men also, it is 50% just like. So to say a 75 kilogram person, 35 liters will be the water. This is distributed into two major compartments. One is the extracellular compartment. The other is the intracellular compartment. Extracellular, outside the cell, liver cell, kidney cell, skin cell, whatever cell is there outside the cell. And remaining is intracellular. 40% is intracellular, 60% is extracellular. Among the extracellular, there are two components again. The one which is in the vessel as the plasma, the one which is in the interstitium. What is interstitium? This is the tube in which blood is circulating. This is the cell. The space between the cell and the tube is called the interstitium. So 2.5 liters is in the plasma. Remaining part of it is in the interstitium. Intracellular fluid is cytoplasm. Such cell is liquid. That liquid is cytoplasm. That is again water. So generally, this is the understanding. You have to, this shift occurs between the plasma and the interstitium, between the interstitium and the intracellular. So intracellular, interstitial, intravascular. The shift can occur between them, isn't it? So that is the important aspect. Now look at this diagram. We have total of how many? Total body weight, 60%, a 70 kilogram body weight man. So the 60% of the body weight is 42. So that is the total body water, 42 liters. This 42 liters, 2/3 is distributed in the intracellular fluid. That is 2/3 of the total body water. And 1/3 is distributed into the extracellular fluid. Out of that, 3/4 is in the ISF, and 1/4 in the intravascular. So in a way, you can see the numbers. If 3.5 liters is there in the plasma, around 10.5 liters is in the interstitium, and 28 liters is the intracellular fluid, and totaling to 42 liters. A 70 kilogram man, 60% of the total body weight we take, 42 liters. Major portion is intracellular, 42 liters. And the remaining 12 liters is distributed as 3.5 intravascular, that is the plasma, and 1 to 10.5 the interstitium. And what is the distribution of the various ions? It's not that the interstitium, intravascular and the intracellular compartment is not same. The milieu is different in the blood vessel and in the blood cell and the interstitium. The relative distribution of electrolyte components, the major cation is sodium in the extracellular. You can see sodium is the major cation and potassium is the major cation in the intracellular. Extracellular fluid, sodium is the major cation. Calcium is more or less same. Magnesium, more in the intracellular fluid. Chloride, more in the extracellular fluid, less in the intracellular. Bicarbonate, less in the extracellular, more in the intracellular. So what are the major cations in the extracellular fluid? Sodium, chloride. So of course, chloride is a negative ion. Chloride, bicarbonate are the two anions. And sodium is the major cation in the extracellular. Intracellularly, potassium is the major cation. Bicarbonate also is major anion there, and chloride is less. And magnesium also is there. Phosphates are there. Protein cations are there. Phosphate cations. So the distribution is not the same in the extracellular and the intracellular fluid. Okay. So approximately 2.54 liters of water we drink, including the water in the vegetables, rice, everything, whatever is. Out of that, 1.5 is taken as fluid itself and 0.5 as the food that we eat, and biological oxidation is 0.4. What is biological oxidation? You know, every glucose molecule, finally when it is metabolized, carbon dioxide and water. So that water is the metabolic water, biological oxidation water. That is 0.4 liters. 0.5 is the food that we contain, and 1.5 is what we drink. This is normal distribution. It can vary depending on the environment. Hot environment, you consume more fluid, and colder environment, you consume less. Approximate output also is 2.4. That is why the fluid balance is there. They are not becoming edematous. They are not becoming very dehydrated because the input is same as the output. How does it go? 1.5 goes through the renal system. That is urine. 0.4 perspiration. And loss in the breath is 0.4 and fecal loss is 0.4. This again, you know, in a place where it is humid and very dry, the urine output is going to be very much more because perspiration also will be more. So depending on the condition, this can slightly change. Now you have to understand this concept of osmolality. There are two words, osmolarity and osmolality. We are interested in the osmolality. Osmolality of the plasma, osmolality of a fluid, particularly the plasma, is important. What is the formula? 2 times of sodium plus potassium plus glucose divided by 18, 1 divided by 2.8. Now I'll give you an example. A person has got sodium 140, potassium 4, glucose 180, 128. Take an example. Sodium is 140, potassium is 4. I am not looking at that slide. I am giving my own example. Glucose is 180, 1 is 28. Now calculate the osmolality. 140 plus 4, 144 into 2, 144, 288 plus glucose 180 I said divided by 18 is 10. So 288 plus 10, 298 plus 28 divided by 2.8 is again 10. 298 plus 10 is 308, which is much higher because it is a hyperosmolarity. Normal osmolarity of plasma is 280 to 285. The normal osmolarity of plasma is 280 to 280. In the given example on the slide, you can see 132 sodium, potassium is 4, 132 plus 4 is equal to 136, multiplied by 2 is equal to 136 into 2, and 108 divided by 18 is 6, and 14 divided by 2.5 is equal to 5. So 272 plus 11 is 283 normal plasma. Now, can you, any one of you, tell me why we are dividing that glucose by 18 and 1 by 2.8? Pardon? What are the units of sodium and potassium? Milliequivalents. What are the units of measurement of glucose and 1? Milligrams. I want to convert, everything should be in the same unit, no? If something is in milliequivalent, I can't add milligrams to that. See, you have 5 rupees, you have got 500 rupees. I can't add 500 plus 5 plus 5, 10. This is 100, this is 5. So then you have to equate properly. So that means 118 is the equivalent weight to convert the milligrams into milliequivalents, and 2.8 is the equivalent weight for 1. So that you divide by that, it comes into milli. So now everything is in milli. This is the formula. All of you must remember that. Now you tell me, well, how do you calculate osmolarity?
Sodium plus potassium is 2 plus glucose by 18 plus 1 by 2.8.
Exactly. In urine osmolarity also, this is the same formula. But the difference there is, there will be some potassium maybe a little different, and there will be other ions will be there. I will give you the urine osmolarity later. First of all, let us look at the plasma osmolarity, which is very important to understand this lecture. So, the effective osmolarity is what? Effective osmolarity is what are the two important ones which are contributing? One is 4, the other is contributing. 1 is also usually not very high. It is glucose and sodium which are maximum contribute. Because 2 times sodium itself, 135 into 2, 270. Out of 285, 270 is already sodium. So the major player for osmolarity is sodium. That is why hyponatremia is important. A little shift in the sodium will change the osmolarity. Likewise, the major contaminant for the osmolarity could be glucose, because this can shoot up to 400, 500, 600. So this can contribute to increase in the osmolarity. So the two important players are sodium and glucose. Potassium generally is around 4, 4.5 at the most 6, and beyond that patient will not. 1 is also generally, unless there is renal failure, it's not. So our major players are, the major effective determinants are glucose and sodium. Okay. Another important thing is all substances do not contribute to the osmotic pressure. Only certain substances are osmotically active, certain substances are not osmotically active. Now, let's come about the sodium. It is the major cation in the extracellular fluid. 140 milliequivalents is the load in the ECF, 25 in the intracellular. Total body is 5,000 milliequivalents of sodium. How do I get it? For every liter, I have got 140 milliequivalents in the extracellular fluid and 25 in the intracellular fluid. Total body water is 60% of the 70. So if you use that number and multiply, roughly it comes to 5,000 milliequivalents is the total. Out of that, 85 to 90% is in the extracellular fluid. Okay. So this is responsible for 90% of the osmolarity is by the sodium. 280 is the normal osmolarity. This itself is contributing 140 into 2 itself is 280. So this is the major player as far as what is the daily requirement of sodium? The daily requirement of sodium is 100 milli equivalents. 100 milli equivalents, supposing I ask the patient, take 100 milli equivalents of sodium. What does he do? How does he know what is 100 milli equivalent? He cannot. You have to convert it to grams. So if you want to convert the milli equivalents into grams, 6 grams of NaCl or 2 grams of sodium contained in NaCl. Because Cl contributes to some weight, Na contributes to some weight. So 2 grams of sodium or 6 grams of sodium chloride tables is equivalent to 100 milli. That means what should be your intake? Not more than 6 grams of salt per day. Okay? For one individual. Supposing a family of 4 are there. How many grams is it? 24 into 30. How many grams are there? 750. But how much salt thereby? 1 kilogram, 1.5 kilogram. All that has to go through the kidney. So tax deduction at source. That means do not buy more than 500 milligrams. 500 grams of salt. Why? I require only for 4 people 750. Remaining 250 is coming in my vegetables, in my cereals, everything else in my milk has got this sodium. So if you have 500 grams of salt per family of 4 or 125 per individual, it is more than adequate. All of us, particularly we Indians, lot of pickles, papads, kurkures, karkares, all these things we add. These are highly rich in sodium. The salt fish is very highly rich in sodium. This throws a lot of burden on the kidney. Remember, when you advise a patient of heart failure, you should not consume more than 2 grams of sodium or more than 6 grams of salt per day. That is the prescription meaning. So this is called Na because its Latin name is natrium. Natrium, that is why Na is this one. Now we need to understand the hypothalamic pituitary endocrine axis. The master controller is the hypothalamus. It mediates its control through the pituitary, and there is an endocrine axis that is through the aldosterone and ADH. That axis we have to understand. Now, there is what is called vasopressin. Vessel, pressin, which pressin? Vasopressin, vasopressin. The other name for antidiuretic hormone is vasopressin. It is called AVP. Why it is called AVP? There is an arginine molecule in the vasopressin. That's why it is called arginine molecule. It is also called antidiuretic hormone. If this hormone is more, there will be less diuresis. If this hormone is suppressed, there will be more water will be excreted. There will be diuresis when ADH is less. There will be no diuresis when ADH is more. So it is synthesized and secreted by the neurohypophysis, the posterior pituitary, and the hypothalamic nucleus. Now, this is a very interesting slide which all of you should do. On the x-axis, we have got the osmolality starting from 275 to 295. Why we get 275? Below 275, it is very dilute plasma. About 295, it is a very concentrated plasma. The situation is usually between that. What is the midpoint? Around 285 is the normal plasma. When the normal plasma osmolality is there, the amount of ADH secreted is 4 picograms per ml. In a normal plasma osmolality, the amount of ADH secreted is 4 picograms per ml. Supposing I go to point A there. What is point A? Point A is the plasma is dilute. It is not 285, it is instead 280. When the plasma is dilute, what will happen? Already there is water in the plasma. So that there should not be any antidiuretic hormone, antidiuretic hormone should be suppressed, so the water is thrown out. So ADH is 0. When the plasma osmolality is lower, ADH is 0 picograms. On the other hand, if you shift to the point B, where the plasma osmolality is higher, we require water to be conserved. Antidiuresis hormone is required, so it comes, and that is equivalent to roughly 8 picograms of the ADH. So what did I learn? Normal plasma osmolality is around 285. The number of units of ADH secreted is 4 picograms per ml. At that point, if the plasma is dilute, that is shifted to the A side, then naturally no ADH is required, it is suppressed. If the plasma is concentrated more towards 295, then naturally I require the ADH to be more so that the water is conserved and the high osmolality is lowered by diluting the plasma. You understood that? It's important. Now, how is the water handled? The water is handled in 2 ways. One is increase in the extracellular fluid osmolality. Extracellular fluid, that is the ECF. Extracellular fluid means plasma. Interstitium and plasma is the extracellular. Extracellular fluid osmolality is increased or circulating blood volume is decreased. There are 2 possibilities. For example, a patient has got diarrhea and vomiting. What will happen? The circulating blood volume will come. The other way around, if there could be an increase in the anions and increase in the osmotic ions like glucose and sodium, which can increase the ECF. So if there is an increase in the ECF, that triggers the osmoreceptors in the CNS. These CNS osmoreceptors directly act on the hypothalamus to produce ADH release, and antidiuresis occurs. Antidiuresis means diuresis is prevented, the water is conserved, the extra ECF is diluted now, and then ECF osmolarity is brought down. That is one mechanism. The other mechanism is there is a decrease in the volume in the blood due to the loss of fluid, diarrhea, vomiting, let us say. Then the other receptors are the baroreceptors. These are pressure sensitive receptors. The other ones are chemoreceptors, osmoreceptors. These are pressure receptors. These are the carotid and carotid artery, aortic body, carotid arch, aortic arch and carotid. They stimulate angiotensin 2. Angiotensin 2 is a dipsinogen. It produces thirst. Angiotensin 2, that produces ask the patient to take more water. He is thirsty, he will take water. Then, because the volume is decreased, he has taken water, volume is maintained, circulating blood volume improves, and the ECF osmolarity is decreased. So, I now know that the water metabolism is basically dependent on 2 axes. One axis is the ADH axis, which is sensitive to the chemoreceptors or the osmoreceptors, sensitive to the ECF osmolarity. That is in turn sodium and glucose. We have seen that those are the 2 major players. The other axis is the baroreceptors, which are sensitive to the circulating blood volume. If the circulating blood volume drops, or if the plasma osmolality increases, there will be ADH secretion, there will be angiotensin secretion, both together will pull the volume up and push the osmolality down. This is an electron micrograph of the Bowman's capsule. In the kidney, you can see the bigger arrow in the center, that is the basement membrane. So can you see that? Is this mouse visible there? So this is the basement membrane. And there are 2 sides of the basement membrane, the urinary space side and the capillary side. One is the capillary side, basement membrane, urinary space side. On the capillary side, there are endothelial cells of the capillaries. And in between there are pores. Those pores permeate water, electrolytes, glucose and all the molecules, but not protein. That's why you don't know proteinuria. Unless the openings are wider, and the basement membrane is damaged. There could be disease in the basement membrane, which will make it less permeable or more permeable, then all the problems. On the urinary side, you have got the foot processes or the podocytes, something like, a foot, elephant foot, you see, something like that it is. These foot processes, there is a slit diaphragm between one podocyte and the other one, and that diaphragm also is activated by various mechanisms to allow the urinary contents to get into the capillary endothelium or capillary contents to get into the urinary space. This is the Bowman's capsular. Basically, there is an endothelial lining on the capillary side, which has got fenestrations. Then there is a basement membrane on top of that, which is again a limiting factor for the transfer. And there are podocytes, which have again in between them, there are pores there, and there is a filtration diaphragms that are there. You understand? Now, would have studied in your physiology countercurrent multiplier and countercurrent exchange system. It is a big bugbear for all of you. When you are asked to write an essay on countercurrent exchange and countercurrent multiplier, very few students will be able to correctly answer because we have not understood what it is. Okay, I am not going into the renal physiology now. I am interested to show you how water is moving in the nephron. So it's filtered, and the part above is, this part is the proximal convoluted tubule, then is the loop of Henle, then the distal convoluted tubule, the collecting ducts, and then the outer medulla and inner medulla. Now, recently, around 15 years back, a beautiful discovery was made about the aquaporins. Aqua, water, porin, channel, pore, aquaporins. These aquaporins are 1, 2, 3, 4 in number as far as kidneys. There are other aquaporins in GI tract glands, but here we are interested in the 4 aquaporins. Aquaporin 1 is present in the proximal convoluted tubule and in the descending limb of the loop of the Henle, and it is not under the influence of ADH. ADH comes and tells open, no, you are not my boss, I won't open, because it doesn't hear. Aquaporin 1 is not controlled by ADH, whereas aquaporin 2, 3, and 4 are populated in the distal convoluted tubule in the collecting ducts, and they are responsive to the ADH. It's a fundamental understanding. Which aquaporin channel is under the control of ADH? Aquaporin 1 is not. 2, 3, 4 are. Aquaporin 1 population in the proximal convoluted tubule, the descending limb of the loop of Henle, and the loop of the Henle, and the aquaporin 2, 3, 4 are in the distal convoluted tubule and in the collecting. This is very important. Now, let's go to the next slide. How much water is filtered normally at the glomerular membrane, basement membrane? What is the glomerular filtration rate? 120 ml, isn't it? Per minute. Multiply into 1 hour, how much comes? 120 into 60. Per day into 24. How much it has come? Work on the calculator. 120 is the GFR. Okay. You are measuring the eGFR, estimated GFR from creatinine. If it is less than 90, the renal disease, normal 90 to 120. So GFR is 120. 120 into this per minute, per hour into 60. Per day, how much it is? 180 liters of urine is filtered. 180 liters is filtered. What is our blood volume? 5 liters. It will not be sufficient for even 10 minutes for the filter. Then what is happening? All this 180 liters that is filtered is taken back and reabsorbed and conserved. This is the best example of water conservation in the whole world. We are asking you to conserve water, save water, all that. Kidney is demonstrating to you that it filters 180 but excretes 1 liter. 179 it is reabsorbed. Isn't it? So that is a wonderful message to all of us to conserve water. Now, out of this 180, you see in the first part, 180 liters is filtered, and this water is going into the interstitium and reaching the capillaries and vascular system through the proximal convoluted tubule. By the time it comes to the end of proximal convoluted tubule, only 36 liters is there. That means 70% of the water is already absorbed by the time of proximal convoluted tubule. Then you may ask me, why filter 180 and excrete only one? It can as well filter only 1 liter. Why it is filtering 180 liters? See, why first filter, then take trouble to absorb again back? Because all the solutes have to go. Solutes cannot go unless they are in solution. But the solution may require water. So water has to go. If you want to flush the toilet, you use 5 liters or 10 liters of water. Likewise, the kidney tries to flush the solutes and waste products, urea, nitrogen. And for that, it requires water to come down. Water is very precious, it knows. It draws it back into the system. Okay, 70 to 75% of water is already reabsorbed by the proximal convoluted tubule, which is not under the influence of ADH because it is controlled by the aquaporin 1 channel. Now, in the loop of ND, some more changes occur. Water migrates into the interstitium. By the time the distal convoluted tubule starts, 24 liters. From 36, it has come to 24. So some more water reabsorption has occurred. And that 24, again through the DCT, the light blue part, some more water is absorbed. And by the time it comes to the end of the tubule, the collecting duct into the pelvic calcium system, it is 1 liter a day. So what is 180 liters has become 1 liter. You can see the dark blue lining for the collecting duct and the DCT. What is the dark blue lining? That is the one under the influence of aquaporin 2, 3, and 4. Now I am showing a microphotograph of that cell, This cell again has got 2 surfaces. One is called the luminal surface on the left side. The other is called the interstitial surface on the right side. Center is the cell. Cell is like this. This is the luminal side. This is the vascular side. That cell is containing the aquaporin channels. And there is a receptor called the AVP receptor or V2 receptor on the basolateral side of the collecting of that particular cell. And the V2 receptor is that. You can see the V2 receptor. That is the vasopressin receptor. So what will happen? Vasopressin will come there, arginine vasopressin, ADH, it will sit on the receptor and it activates a chain of chemical reactions. Cyclic AMP is produced. The cyclic AMP opens the vesicles there. There is a vesicle, white one, and vesicle has got the tubes. Those tubes are the aquaporin tubes. These tubes are exteriorized. Till then, they are inside the cell. Once the cyclic AMP comes and tells them you are required, the water is coming, you better go there and stand at the entrance of the particular, that side of the pond. The aquaporins go and open and bring the water into the cell. But water should not be in the cell because this will swell and die. Naturally, the aquaporin 3 and 4 are on the other side. Those channels are also open. Whatever comes, it is not like a diffusion through the cell membrane. For a molecule of water to cross the cell membrane, it takes energy and time. If there are tubes, the pipes, it will straight. This is the mechanism by which water reabsorption is under the control of the ADH. Then, in the absence of ADH, what will happen? Arginine vasopressin receptor is not occupied, it is not stimulated, cyclic AMP is not triggered, and the vesicles are not broken, aquaporin channels are not open. There is no messenger to carry the water from this one to this one into the interstitium. Water remains in the urine is excreted, diuresis occurs. When ADH is there, it absorbs, anti-diuresis occurs. You understand? For this, Peter Agre, AGRE, was given a Nobel Prize around 18 years back for detecting the aquaporin channel. He got a Nobel Prize for this detection. Till then, no one was knowing how the arginine vasopressin is able to bring in so much amount of water into the system. This calculation I have already told you, 120 million ml per minute into 60 into 24, around 170. Only 1.5 to 2 liters of water is excreted. 99% of the filtered water is reabsorbed. 1% only is finally excreted. 70% completed in the PCT by aquaporin 1. Just 29% by aquaporin 2, 3, and 4. Reabsorption of water in the collecting duct is ADH mediated. I summarized whatever I have. How does water conservation occur? We have seen in the previous slide. By a decrease in the plasma volume or an increase in the osmolality. There are two triggers. A volume can decrease and stimulate the baroreceptors through the angiotensin 2, which is a dipsinogen, conserve water, drink more water, and keep the volume intact. Or the extracellular fluid osmolality is increased, AVP is released. AVP is antidiuretic hormone. It goes to the receptor there and it stimulates that. Aquaporin channels are open and all the water from the urinary space is brought into the vascular space. So the osmolality is brought down, which is high now, is now brought down. Without AVP, there will be water dilution. So complex interactions are occurring between what? Plasma osmolality, plasma volume, the thirst center, the kidney, posterior pituitary, and the hypothalamus. These are all together orchestrating, and we do not know how we are happily walking with good water balance, without any positive or negative balance. This is happening on its own, without our knowledge. Dysfunction in any one of these areas can result in hyponatremia. Why all the story about water? Because we are interested about hyponatremia. A change in the plasma osmolality, a change in the plasma volume, an excessive stimulation of thirst center, either by psychogenic polydipsia or by the dipsinogen that is secreted, the angiotensin, or the kidney disorders, pituitary disorders, hypothalamic disorders, all have a role to play in hyponatremia. Okay. Now, the clinical disorders of water balance, not sodium balance, water balance. You all know waterlogging conditions, cardiac failure, cirrhosis, renal failure, hyper and hypothyroidism, Addison's disease, central diabetes insipidus, CDI. I will tell you one day about diabetes insipidus. Diabetes is a common thing, but diabetes insipidus is not known to you so clearly. I will show you how to differentiate. Nephrogenic diabetes insipidus, psychogenic polydipsia or compulsive water drinking, and pregnancy is also a waterlogging condition. These are the waterlogging conditions. Okay. Now, so we are now, and till now we have spent time on water balance and interactions, the physiology behind the ADH, the various triggers and all that. Now let us come to the sodium. Defined as serum sodium below 135. What is hyponatremia? Hyponatremia by definition is a sodium value less than 130. Most common electrolyte disorder encountered in clinical practice, and 22 to 30% of inpatients have hyponatremia. This is 1/3 of the patient, or 1/4 to 1/3. So every inpatient, you must check for electrolytes, particularly sodium. Not only sodium, you should check for the osmolality. It is an independent predictor of mortality. Means what? Whether he has myocardial infarction or not, that's different. If he has hyponatremia, he is added risk for mortality. If he has got hypoglycemia or not, no problem. Hyponatremia is a killer by itself. It is an independent predictor of mortality. Usually 50% of the hyponatremia is acute, 20 to 30, 10 to 20% is chronic, remaining subacute. The challenge for the hyponatremia is the moment somebody says hyponatremia, you think about 3% sodium chloride and start it. That's not the way you should do it. You must know the cause of the hyponatremia. As a postgraduate teacher, a postgraduate practitioner tomorrow, going to be teachers also, some of you. And you should not treat any disease without knowing the etiology. So the etiology of hyponatremia, we have to understand. Basically, hyponatremia is water imbalance. That is the underlying state. What is the clinical importance? Acute severe hyponatremia can cause substantial morbidity and mortality. Adverse outcomes are higher in hyponatremia patients with underlying disorder. Same underlying disorder, add hyponatremia, the mortality and morbidity is higher. Third thing is over enthusiastic replacement of sodium produces a condition called central pontine myelinolysis. When it will come, suppose you have given very vigorously for today and tomorrow a patient. Will he develop central pontine myelinolysis tomorrow? After 2-3 weeks, patient may not know that is because of it's good in one way. He will not sue you directly. Suppose you give fluid and evening he develops central pontine myelinolysis and neurological deficit. Yeah, this doctor has given this some bottle like thing, small bottle, and that produced my paralysis. He will know. But here he will not know. You only will know. After 2 weeks only, he will come with central pontine. Very dreaded complication. We will come into that later. Now, so we have defined less than 125 millimoles or milliequivalent, both are same millimoles or milliequivalents. The concentration of ECF is a reflection of the tonicity of the body fluids, and hyponatremia can be associated with 3 types of tonicity. Now, this is the crux of the presentation. Hyponatremia, normal tonicity, low tonicity, high tonicity. Means hyperosmolar hyponatremia, normoosmolar hyponatremia, hypoosmolar hyponatremia. The patient has got, first of all, we ordered electrolytes. Blood report 128 milliequivalent sodium. I'm already worried patient sodium is low. First thing is it normal osmolarity or higher osmolarity or lower osmolarity? If I know, the causes can be separated. How do I know the osmolarity? We have the formula. What all you require is sodium, potassium, and then glucose and 1. Ask for those 4 values. You yourself can calculate. 2 plus sodium plus potassium into 2 plus glucose divided by 18, 1 divided by 2.8 is the answer. I know the osmolarity. I know the normal value also, 280 to 285. If it is between 280 and 280, okay, this fellow has got normoosmolar hyponatremia. Okay, the plasma osmolarity is 75, 275 or 200. Hypoosmolar hyponatremia. It is 295 or 300. Hyperosmolar. Within minutes, you will be able to know to which category it belongs. All you require is, always whenever you ask electrolytes, you also ask for sugar, 1, then sodium and potassium. And the formula is available. Very easy for you to calculate. There is what is called MedCalc. I don't know whether you people use. MEDCALC. An app is there. You can download that app, all of you. And if punch these numbers, it will give the osmolarity. Not only this, it gives many calculations, clinical calculations. MedCalc. Okay. Now, there is one condition called pseudo-hyponatremia. Pseudo means false, not correct, not real. Pseudo doctor means she is not studied medicine, but she wearing coat and treating patients. Pseudo doctor. Like that, pseudo-hyponatremia. What is pseudo-hyponatremia? It is tonicity is either normal or increased. First of all, we have to exclude pseudo-hyponatremia. Any patient coming with hyponatremia, look at the osmolarity and also exclude the pseudo-hyponatremia. Pseudo-hyponatremia does not require treatment. What is pseudo-hyponatremia? Associated with the tonicity will be either normal or increased. is expansion of the extracellular fluid due to isotonic fluids that do not contain sodium. Supposing you are infusing some fluids which are isotonic fluids, non-sodium containing fluids, then you can end up with pseudohyponatremia. What are the non-sodium containing fluids that you put in? Plasma expanders. There's several things, you infuse which do not contain sodium, but they expand this one, they dilute the plasma. Then sodium will be appearing low, apparently. Also, in condition like hypertriglyceridemia, hyperparaproteinemia, there will be a pseudo-hyponatremia. For every raise of plasma lipid 4.6 grams per liter, there will be 1 milliequivalent. Plasma protein also, it changes. So what do I require? Along with the values I want, I have to order for serum triglycerides and then serum protein. If the serum triglycerides is normal, serum proteins are normal, I have not infused any fluid which doesn't contain sodium and increases the isotonicity, then I am not in pseudohyponatremia. So now you write down the investigations. A patient of hyponatremia comes, what are the things you require to do investigation-wise? Examination is important. Investigation-wise, ask for sodium and potassium. Then also ask for glucose and bun, and ready to calculate the formula. Look for triglycerides. Look for proteins. The paraproteins are best identified by an electrophoresis of the protein. If you do an electrophoresis, the Benz and urine Benz-Jones proteins will be present. The paraproteins will be, multiple myeloma proteins will be visible. So in the absence of triglycerides, in the absence of paraproteinemia, in the absence of high tonicity fluids being infused other than sodium, if there is hyponatremia, then it is not pseudohyponatremia, because these conditions are excluded. I am dealing with real hyponatremia. We told that hyponatremia can have hypertonic, normotonic, hypotonic. Hypertonic is hyperosmolar, normosmolar, hypoosmolar. Now, we condition called hypertonic hyponatremia. What are the conditions which produce increased tonicity, but sodium is low? Hypertonic, I did a calculation. I got the result 295. Sodium is 128. There is hyponatremia, hypertonicity. So the cause must be different. We have to know what is the cause. Shift of water from the cells to the ECF, thus causing translocation hyponatremia. What happened? The cells have got water. That water is shifted into the ECF for some reason. Because the water is shifted, the tonicity has the shift of water from the cells to the ECF, and there is a translocational hypo. For example, hyperglycemia itself increases the osmolarity. Why? We know in the formula itself, glucose by 18 is osmolarity. Suppose my glucose in the 108, it is 316, 216. It becomes double. And 432, it is 4 times. So it contributes to the osmolarity. Then what do you require? And one more investigation. Blood sugar. Is it like this? If the blood sugar is high, hyponatremia is there. The diagnosis is hyperglycemia-induced hypertonic hyponatremia. Treatment, not giving sodium, reducing the sugar. Okay, how easy it is now. So how much it goes? For every 100 milligrams increase in the glucose, there will be 2 milliequivalents of increase in the fall in the sodium. Likewise, if it is 200 to 400, the fall is up to 4 milliequivalents. Beyond 400 also. Another condition which could have produced is, sometimes we give mannitol. Why do you give mannitol? You wanted to withdraw the fluid from the brain, cerebral edema to reduce, or flow force diuresis. You want to give, you use a hyperosmolar fluid, that is the mannitol. So these are the two conditions which produce hypertonic hyponatremia. Okay. Now, Then comes the hypotonic hyponatremia. This is the commonest hypo. Whenever there is hyponatremia, hypotonicity also is added. Hypotonic hyponatremia is the commonest form. Hypotonic hyponatremia occurs by two mechanisms. One, renal, then excess water intake. Impaired renal water excretion, excess water intake. Hypotonic hyponatremia can be classified now as into three: hypovolemic, euvolemic, hyper. See how many have come? We started with hyponatremia, excluded pseudohyponatremia. Pseudohyponatremia is due to what? Pseudohyponatremia is due to fluids other than sodium going into the body, triglycerides, and also you have got the propara. Then you have come to hypertonic hyponatremia, their mannitol and sugar are the two culprits that you excluded. Then hypotonic hyponatremia. Now I require to clinically examine the patient. Is he euvolemic? Is he hypovolemic? Is he hypervolemic? How do you know? How do you know he is hypovolemic? What are all the signs of hypovolemia? Tell me, hypovolemia clinical signs. Skin turgor is reduced, skin pinching is more, sunken eyes, low blood pressure, there may be tachycardia, there is a dehydration, mucous membranes are dry, skin is dry, dehydration patient, typical cholera patient or gastroenteritis, typical hypovolemic situation. Then how do you recognize hypervolemia? Fluid retention wherever it is possible. In the feet, in the back, in the face, under the lids, in the pleural spaces, in the abdomen, everything. That means there is excess fluid in the body. Hypervolemia. In the absence of these two, the patient has got hyponatremia, means euvolemic hyponatremia. So important for you to know, is it pseudohyponatremia, hypertonic hypernatremia, hypotonic hyponatremia. Once I know hypotonic, sit euvolemic, hypovolemic, hypervolemic, because the causes are different. Now you see, assessment of a patient's volume status. Hyponatremia, hypotonic hyponatremia. This is from your Harrison itself. Harrison's textbook of medicine. Hypotonic hyponatremia classification. Assessment of the volume status. You have done just now what we have done. Then patient is euvolemic, patient is hypervolemic, patient is hyper. One of the three conditions. Now we go to the right hand side. Hypervolemia. That means patient is waterlogged. Hypervolemic hyponatremia. Patient has got demonstrable hyponatremia. His plasma osmolality is hypotonic. Tonicity we have measured, it is less than 280, and he is waterlogged. This is the current situation. What are the things? That means there is more body water and body sodium also has increased. Sodium increased all right, but water has increased more. That is why he is having hypo. Particularly heart failure, cirrhosis, these kind, waterlogged conditions. Now, how do I separate renal failure? Also, there could be waterlogging, chronic renal failure. So, how do I separate renal from non-renal waterlogging condition? To urinary sodium. Next investigation required will be urinary sodium. Straight away you order everything, starting with that. Urinary sodium. Suppose urinary sodium is more than 20. Means what? He is not able to conserve the sodium. That is, the sodium is going in the urine. Urinary sodium more than 20 means there is loss of sodium in the urine. That is chronic or acute renal failure. Water is retained, sodium is lost. That is why water is retained, volume has gone up, sodium is lost. osmolality has come down, hyponatremia, hypotonic, hyponatremia with water. The other way around, urinary sodium is less. Oh, now body knew that there is hyponatremia, it wants to manipulate through the kidney, so it will not allow the sodium to go out. Wait, you are required, there is hyponatremia. You cannot go out just like that. So you are required here. Kidney is absorbing the sodium. That is why the urine sodium is lesser. The conditions are nephrotic syndrome, cirrhosis, cardiac. So where we started, patient had hyponatremia, then we measured osmolality. Osmolality is lower, hypotonic hyponatremia. Then we examined him. Examination hypervolemic, is waterlogged. Then I examined urine sodium. Urine sodium is more. Okay, urine kidney is throwing away the salt. Acute or chronic then. Urine sodium is less. That means the kidney is ordered to conserve sodium because of hyponatremia. That is in heart failure, nephrotic cirrhosis. Now, move to the leftmost part. Hypovolemic hyponatremia. This fellow has got hyponatremia, hypotonicity, and when I examined, he is dehydrated. And there is hypovolemia. Blood pressure is low. And then highs are sunken, skin turgor is lost. And then the mucous membranes are dry, skin is dry, hypovolemia is there. Then again, I depend on the urine sodium. Why? He is the loss occurring through the kidney or outside the kidney. Is the kidney is the culprit or extrarenal causes are the culprit? Renal causes, extrarenal causes. What are the renal causes? Diuretic excess. Okay, somebody asked the patient to be given 40 milligrams of Lasix. The nurse has given 40. The duty doctor has given another 40. And then the consultant, the junior consultant, he has also given another. So excessive diuresis has been prescribed, inappropriate use of excessive diuretics. That is one cause, common cause. Then what happened? Fluid has gone, sodium also has gone, there is hyponatremia, hypovolemia, hypotonicity. Then what else? Mineralocorticoid deficiency. Mineralocorticoids are required, they are sodium conserving hormone, aldosterone. Aldosterone deficiency, mineralocorticoid deficiency, there is no aldosterone, there is nobody who is holding the sodium, and sodium is absorbed, reabsorbed under the influence of aldosterone. Aldosterone is not there, sodium is wasted, along with sodium, water also has gone out, because it will not go alone, always it wants a friend. When sodium goes, water also follows. So what happens now? There is hyponatremia, there is hypovolemia, there is hypotonicity. Salt losing nephritis. That is also another condition called the salt losing nephritis. Then bicarbonaturia. If there is a bicarbonaturia due to metabolic alkalosis, bicarbonate metabolic acidosis with bicarbonate urea, along with the bicarbonate sodium also. Ketonuria. Okay, osmotic diuresis. Osmotic diuresis is again your diabetes itself is a great osmotic diuresis. And cerebral salt wasting syndrome. These are some rare causes. Common cause, excessive diuretics, mineralocorticoid deficiency, bicarbonate urea, salt losing nephritis, ketonuria, and chronic osmotic diuresis. Okay, why? I know that sodium also is going because urine sodium is more than 20. Now, let me look at the urine sodium less than 20. Kidney is not throwing the sodium out. Something else is throwing the sodium. From where? The GI tract, gastroenteritis, vomiting, and then third space sequestration. What is third space? Abdominal cavity, pleural cavity. Anywhere, edema and third space sequestration. In that, the sodium is there, is locked there. So there is no sodium here, but the urinary sodium is less. Because of the extrarenal causes, the kidney is trying to conserve the sodium. So much so urine doesn't contain more sodium, less sodium is there. Burns, what will happen through the skin? Lot of fluid is oozing out. That fluid also extrarenal loss of sodium and fluid. And acute pancreatitis. produces vomiting as well as loss of fluid and trauma. Okay, leave it. So these are the causes of hypovolemic hyponatremia. So the patient presents with hyponatremia, assess the osmolality, hyperosmolar, pseudohyponatremia you remove. Hyperosmolar hyponatremia is there are two conditions there, the, the sugar and mannitol. Pseudohyponatremia, triglycerides and paraproteins that we have excluded. And then we come to hypovolemic hypotonic hyponatremia, assess the volume, hypovolemic hyponatremia, hypervolemic hyponatremia. If it is hypovolemic, is it kidney or is it extrarenal? If it is kidney, sodium will be more than 20 because kidney is throwing the sodium out. What are the causes? Excessive diuresis, and then the mineralocorticoid deficiency, salt losing nephritis, bicarbonaturia, ketonuria, osmotic diuresis, cerebral salt wasting syndrome. When you have urine sodium is less, that means the cause is not kidney is not the culprit, something else is throwing the sodium out. Must be sodium, must be gastroenteritis, vomiting, diarrhea, pancreatitis, third sequestration, and then burns. Another important thing is sometimes what we do is we create a sort of cecal pouch we will create, and then the urine is allowed to drain into the vesicocecal pouch, vesicocolonic pouches are created, and then those are also then used. This is surgical condition. Leave it. And then hyponatremia with hypervolemia could be renal, it could be extra-renal. If it is renal, urine sodium should be more than chronic and acute. If the urine sodium is less, kidney is not the culprit, kidney is even trying to conserve sodium, must be extra kidney, outside the kidney, cardiac failure, cirrhosis of liver, and then nephrotic. Then you are left with only one condition, euvolemic hyponatremia, hyponatremia, photonic, euvolemic, then here euvolemic, no edema is there, no dehydration is there. This means glucocorticoid deficiency, and then hypothyroid, stress, drugs. Most important is CR, syndrome of inappropriate secretion of antidiuretic hormone. That is the common condition which is responsible for euvolemic hypotonic hyponatremia. And if we will stop here, try to look at the next part of it. Total some 70 slides are there. We have come up to 27 slides. But we are going slow, does not matter. We'll try to understand this differential diagnosis. I will give you an algorithmic approach. What step by step, how do you take it? Once you understand the basis of it, the pathophysiological basis, then I'll give you the algorithm approach or practical approach. The next, how are you all placed on Friday, coming Friday? If you can attend, I can come again on Friday. How many are possible? How many it is possible to come on Friday? Friday bit same time, 2:30 to 3. We'll finish hyponatremia. Now, did you get some idea how we are going? Not that simply hyponatremia, sodium 128, give 3%. No. Nowhere we have mentioned to give 325 here. We treat renal failure, we treat diabetes, we treat diarrhea, we treat vomiting, we are not giving anything. We are attacking the underlying cause, isn't it? That's how you have to go about. So read that notes, this PPT also I will share.